Hello everyone, welcome back again to my channel. So if you are new here, welcome and thank you for tuning in. So just to introduce myself, my name is Annie. I am a nurse here in North Carolina and I have been here in the United States since 2016. So this channel actually is all about nursing, my nursing adventures, my American dream and everything in between. So if you want to be inspired, motivated, or just even be entertained, then be sure to hit that subscribe button and let's connect. So today's video is the third video of the series, the most common medical surgical cases that we get on our floor. And of course, as usual, just a disclaimer, my friends, whatever I will be sharing with you on this series are just based on my experiences and the cases actually that we admit on our own medical surgical floor. Because as I've said on my previous video, some hospitals has their own subspecialties. So for example, the cardiac units, the nephro units, which cater to the specific patient population with which in our hospital are admitted on the medical surgical floors. So just bear that in mind. So on this video, I will be sharing with you about pulmonary embolism admissions that we have on our med-surg floor. So again, if you are interested on this topic, then keep on watching. And by the way, again, just to reiterate, I won't be going over into perfect details about the disease processes of these cases, perhaps from emergency department to discharge, and not the complete disease processes from pathophysiology and signs and symptoms and everything. It's just the basic things that we do on this patient population on our med-surg floor. I actually picked pulmonary embolism to share with you today because just my previous video was chest pain, so it's just like some tests, diagnostics, some presenting signs and symptoms, and even treatments are actually similar to PE. So the definitive diagnosis that differentiates it from chest pain is the CT scan, which of course shows pulmonary embolism. So patients with PE presents to the emergency department with varied presenting signs and symptoms, but most commonly here are chest pain, increasing shortness of breath, and these patients actually feels very short of breath even with minimal exertion or ambulation. So in ED, of course, they will do all the lab works, the ABGs, cardiac enzymes. It's just like, as I've said, similar to the diagnostics and tests of patient that presents with chest pain. However, with PE, their cardiac enzymes are mostly negative, which of course positive with true chest pains. So their cardiac enzymes are negative, chest x-ray will be normal, of course lab work, CBCs, lights would be unremarkable, and as I've said, the only definitive diagnosis for this PE is the CT scan, which of course shows pulmonary embolism. And in emergency department, they are usually given aspirin, steroids, pain medication, of course, breathing treatments. They will be hooked to oxygen if needed, especially if they have hypoxia. And apart from those, if the patients are noted to have worsening respiratory status or hypoxemia, they are usually started on Lovenox or at least some kind of anticoagulation. Some patients also are noted to have high creatinine, which makes them not to tolerate contrast. So of course, CT contrast is not feasible. So sometimes the doctors would be ordering VQ scan just to check their pulmonary status. And then of course, the patient would be admitted on the medical surgical floor. So you would note that the patient would be ruled out for ACS. So the doctor's order would include, of course, telemetry monitoring, beta blockers, aspirin, oxygen as needed, of course nitroglycerin for chest pain. Sometimes the doctor also will order stress test and echocardiogram just to rule out any cardiac involvement. And of course, similar to chest pain, they will be ordered cardiac enzymes ×3, 6 hours apart, and of course EKG if need be. And I almost forget, of course, the doctor would be ordering some pain medication for this patient apart from the NTGs that they order. Most usually, they will be ordering morphine unless otherwise the patient is allergic to such medications. Sometimes these patients who are admitted for pulmonary embolism actually are started on heparin drip. And of course, as a nursing intervention, you would be monitoring for PT-PTT or their coagulation profile. And of course, not to mention, you should be monitoring them with any side effects or adverse reaction of this medication, which includes but not limited to active bleeding or unusual bruises. If it occurs, you should inform the doctor or the provider so that they can be managed accordingly. Either the heparin drip will be adjusted or stopped totally. However, in our hospital, if the patient is on heparin drip, the pharmacy actually is taking care of the management of that medication, of that drip. So they will be monitoring, of course, their PT levels. So according to the PT levels, they will be ordering some adjustment of the heparin drip. And of course, they will be ordering the next PT level schedule. But of course, as the nurse, you have to make sure that those lab draws are done so that the heparin drip would be adjusted by the pharmacy accordingly, isn't it? Another thing I would like to stress out on these PE patients is when I said these patients felt really dyspneic or really short of breath even with very minimal exertion, that is really true, because we had a patient before who was diagnosed with bilateral pulmonary edema. He was just trying to use the commode actually, and with that very minimal exertion, he was actually alert and oriented. He was just on room air. He didn't need any oxygen, and with that very minimal exertion, actually he was just really short of breath, and actually he almost passed out. He was cold and clammy, and we had to carry him back to the bed, and that of course necessitates us to call rapid response for this patient. So what I mean is just be very vigilant to this patient population. As they say, with PE, you just can't really predict, or you just really don't know what will happen next. So if you are the nurse taking care of this patient, then just be very vigilant. I'm telling you, always go and assist the patient every time they wanted to get out of that bed, because you really never know, isn't it? And of course, with pulmonary embolism, you would expect that this patient would be admitted for a few days, especially if they are on heparin drip, until their INR would be on a therapeutic level, or the target goal for INR will be reached. And upon discharge of this patient, of course, they will be expected to be going home with some form of anticoagulation. And that anticoagulation would perhaps be for life already. So, of course, as the nurse, you are also expected to give discharge education for these patients. You can, of course, educate them with home care or how to take care of themselves, which includes, of course, taking their medications as instructed by the physician, or doing their lab results as recommended by their doctor. And of course, you can educate them with lifestyle changes, which includes maintaining a healthy weight, or stop smoking if they are smoking, or of course, maintaining a healthy diet and all those good stuff. And another thing, you have to educate them of their follow-up to their physician or to their PCPs. And of course, don't ever forget to tell them when to call the provider or when to go to the emergency department, of course, if symptoms persist or they have unusual signs and symptoms that they experience along the way, those kinds of stuff. Those are the things that you can always educate the patient with. So there you go, friends, with my video for today, and I hope you have learned a thing or two again on this video. And if you did, please don't forget to hit that like and share button, and of course, for those of you who haven't yet, please do hit that subscribe button and connect with us. So thank you once again, friends, and see you again on my next video. Bye bye.